Welcome to Andre's Insight, where clarity meets curiosity.
And today we are really embarking on, well, a proper deep dive. We've pulled together stacks of research, really, to try and decode the modern therapy landscape.
Yeah, it's complex out there.
It is. And our mission really is to go way beyond just knowing the names, the acronyms for different therapies. We want to give you, the listener, a much clearer map, something detailed enough to help you make genuinely informed decisions about mental health care.
That's exactly right. I mean, when you look at the sheer range of options available now, you've got structured talk therapy focused on thoughts, then body-based methods working on the nervous system, even these really specialized areas like financial psychology.
It can definitely feel overwhelming.
Totally. So our goal here is structured exploration. We're trying to move past that idea of a single magic bullet solution.
Because there isn't one.
Right. Human suffering is just...
There.
It's intricate. It needs different lenses, doesn't it?
Yeah.
We need to look at the brain, sure, but also the body and the whole life context around a person.
Exactly. We need to understand the mechanism. How does each approach actually work? That's the key to finding what might genuinely align with your specific, unique needs.
Okay, so let's start with probably the most well-known modality, the one many people encounter first, cognitive behavioral therapy, or CBT.
Often the first one taught in psych programs.
Yeah. And when we unpack this, it seems like it's fundamentally about skills and, well, logic almost. So let's break it down. What are the core mechanics? How does CBT actually function?
Well, CBT is really defined by its structure. It's typically very goal-oriented, often time-limited, not open-ended forever.
Right.
And it's based on this really elegant but powerful premise. Your thoughts directly influence or mediate your emotional state, and then your behavior follows from that.
So thought, feeling, action.
Pretty much. So if you can change the way you think, the theory goes, you can change the way you feel and how you act. The main strategy, therefore, is what's called cognitive restructuring, which basically means teaching you skills to actively identify those negative or unhelpful thoughts, question their validity, and, effectively alter those problematic mental patterns.
It sounds like being given a toolkit, like a logical toolkit, to sort of manually fix faulty assumptions you might have about yourself or the world.
That's a great way to put it. And that faulty wiring often involves something Aaron Beck called automatic negative thoughts, or ANTs.
ANTs. I always like that acronym. It feels quite descriptive for those little intrusive, self-critical thoughts that just pop up.
It's a really crucial concept in CBT. ANTs are those self-statements that just seem to bubble up involuntarily. They can be really hard to stop or inhibit.
Yeah.
And they're heavily influenced by deeper underlying core beliefs. Beliefs about your own worth, your competence, safety, that kind of thing.
Formed way back, usually.
Often, yes. And what's critical is that ANTs are often reflexive. They might develop after a really stressful event or a series of them. They become the mind's sort of involuntary shortcut for interpreting new information and usually interpreting it in a negative light.
And if you don't challenge those ANTs, they can quickly spiral into what are called cognitive distortions, right? This is where your mind starts, well, playing tricks on you, seeing things inaccurately.
Precisely. Cognitive distortions are these systematic inaccuracies in how we process information. They lead to flawed interpretations of reality, often quite catastrophic ones.
Like what? What are some common examples?
Oh, things like confirmation bias. That's where you unconsciously just look for or focus on information that already confirms your worst fears. You completely ignore anything that contradicts it.
Right. You filter reality to fit the negative belief.
Exactly. Or catastrophizing, where you immediately jump to the absolute worst possible outcome for any given situation, no matter how unlikely it is. These aren't like intentional flaws in thinking. They're more like errors in the processing system itself.
And central to CBT, especially for depression, is Beck's cognitive triad. That feels like one of those really foundational theories.
It absolutely is. Beck's triad highlights the systematic negative bias that affects three major areas. And these biases are constantly reinforced by those cognitive distortions we just mentioned.
Okay, what are the three areas?
The self, the world, and the future.
Right.
So someone struggling with depression might see themselves as fundamentally worthless or inadequate. That's the self piece. They might see the world as just frustrating, unfair, defeating. That's the world. And they assume their efforts will inevitably fail, that things won't get better. That's the future.
Wow, that's a bleak outlook.
It is. And modifying those ingrained detrimental thought patterns about all three, self, world, future, is really the core pathway to well-being within the CBT model. And it's versatile, This approach is highly relevant for anxiety, PTSD, even things like eating disorders, because they all involve these deeply problematic cognitive patterns.
Now, okay, despite the name cognitive behavioral therapy, it's not just about thinking, is it? There's a huge behavior component, and that's where some really powerful research-backed techniques seem to live.
Oh, absolutely. The behavioral techniques are indispensable. Take exposure therapies, for instance. The research, systematic reviews consistently show they are highly effective, especially for specific phobias.
Like fear of flying or spiders.
Exactly. If you're terrified of heights, the therapy involves carefully structured, repeated confrontation with that feared situation or stimulus.
Well, gradually, I assume?
Usually, yes, though sometimes flooding techniques are used. But the data overwhelmingly suggests that in vivo exposure, that's real-life confrontation, even if it's gradual, is superior to just imagining the scenario, which is called imaginal exposure.
Why is that?
It seems the physical, immediate feedback to the nervous system is what really recalibrates the fear response. Your body learns directly that the feared outcome doesn't happen, or that you can cope with the anxiety.
So, using that spider phobia example again, imagining the spider might be a first step, maybe, but actually being in the same room as a spider, even if it's safely in a container, that's the proven strategy for real, lasting change.
That's generally the finding, yes. Another fascinating, really effective behavioral technique is contingency management. This is used a lot in substance abuse treatment.
Okay, how does that work? It sounds different.
It is quite different. Instead of focusing on deep history or thoughts, the focus here is on manipulating the environment to change behavior. The goal is kind of twofold.
Right.
First, weaken the cues and consequences that reinforce substance use. Second, simultaneously strengthen positive, sober behaviors.
Okay, can you give us a concrete example?
Right.
Like, how would that reward-punishment structure actually play out?
Sure. So in a substance abuse program using contingency management, a patient might submit urine screens regularly. If a screen comes back positive for drugs, there's an immediate, predictable negative consequence. Maybe temporary loss of a privilege or even a small financial penalty. Conversely, consistently clean screens which promote abstinence are immediately reinforced with positive rewards. This could be vouchers exchangeable for goods or services, maybe positive recognition within the program.
So it's very direct reinforcement.
Very direct. The model assumes that substance use often continues because the perceived positive effects are more immediate than the long-term negative consequences. Contingency management tries to flip that equation, using immediate, predictable reinforcement to motivate abstinence right now.
Right, makes sense. Okay, so that's CBT. Now, moving from that highly cognitive framework, let's look at dialectical behavior therapy, or DBT. This started, I think, in the 80s with Marsha Linehan, for a very specific, complex group of patients initially.
That's right. DBT was originally developed for patients diagnosed with borderline personality disorder, or BPD. This is a condition often characterized by really profound emotional dysregulation, intense mood swings, impulsive behaviors, and very difficult interpersonal conflicts.
And its use has broadened since then.
Considerably, yes. It's now applied to a range of conditions where overwhelming, intense emotions lead to impulsive or self-destructive behaviors. Things like certain eating disorders, substance abuse issues, even treatment-resistant depression sometimes.
Okay, so we established earlier that CBT's core goal is primarily to change problematic thought patterns. What's the key difference in emphasis when we put DBT right alongside CBT?
The crucial difference is the introduction of the dialectical piece. It's about balance. Where CBT heavily prioritizes changing those thoughts and behaviors, DBT insists on holding two apparently opposite truths at the same time: acceptance and change.
Acceptance and change, how does that work?
Well, DBT puts a huge emphasis on accepting the intense emotional experience as valid, as understandable. Often, it explicitly links these intense emotions to things like trauma or growing up in environments where emotions were consistently invalidated.
So validating the feeling first.
Yes. But simultaneously, it focuses on building very concrete skills to change the destructive behaviors that often result from those intense emotions and to improve interpersonal functioning. The core idea is you cannot effectively change something that you don't first accept.
That makes a lot of sense, actually.
Yep.
If you're constantly fighting or judging how intensely you feel, you probably can't access the part of your brain needed to use skills to manage it.
Exactly. You're just stuck in the struggle against the emotion. And the research really highlights why this acceptance piece is so vital. That tendency toward intense emotional experience. It can have roots in genetics, sure, but also very significantly in childhood trauma, things like neglect, abuse, abandonment.
And trauma can actually change the brain.
It can. Trauma during critical developmental periods can literally alter brain structures, particularly in the limbic system, making individuals more reactive, more vulnerable to being flooded by negative emotions. But DBT is fundamentally hopeful. It asserts that emotional control, or maybe better termed emotional regulation, is absolutely achievable, not through just wishing it, but through rigorous learned skills.
And DBT isn't just a once-a-week chat, is it? It's often described as a multimodal commitment. It sounds pretty intensive.
It is a major commitment usually because learning and integrating these skills, especially when emotions are intense, requires a lot of practice and support. Standard comprehensive DBT typically involves 4 key components.
What are they?
Okay, first, there's weekly individual therapy. Second, there's group skills training, usually weekly as well. This is where the core skills are taught in 4 modules: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness.
So individual therapy and group skills.
Yes. Third, there's phone coaching. Patients can call their therapist for brief, in-the-moment coaching on using skills when they're facing a crisis between sessions.
Wow, okay. That's a lot of support.
It is. And fourth, there's a therapist consultation team. This is crucial. The therapists doing DBT meet weekly as a team to support each other, ensure they're sticking to the model correctly, problem-solve difficult cases, and, very importantly, monitor for therapist burnout. Treating individuals with severe, complex problems is demanding work.
Okay, so we've covered therapies focusing quite intensely on the individual's mind, thoughts, and emotional regulation skills. But what happens when the issue isn't solely internal? What if it seems rooted in history or relationships, or the whole system around you? Let's zoom out a bit now and look at psychodynamic and humanistic perspectives.
This is a significant shift in focus. Psychodynamic therapy delves into how past experiences, especially early childhood experiences, unconscious conflicts, and developmental history influence your present feelings, your behaviors, your relationships.
So looking backwards to understand the present.
Exactly. The idea is that current symptoms like anxiety or depression are often manifestations of deeper, unresolved conflicts, maybe rooted in those early relationships or experiences.
It sounds, well, deep. Maybe intimidating for some.
It can feel that way initially, yes, because it requires this deep exploration, and the therapist might seem more reserved compared to, say, a CBT therapist who is actively teaching skills. Progress might feel less linear, maybe a bit slower at the start as you uncover these patterns.
Okay, so that's the psychodynamic approach, kind of like psychological archaeology.
Yeah.
How does that compare with the humanistic model? They sound different.
Oh, vastly different in their philosophical foundation. The humanistic approach, often associated with Carl Rogers, is really centered on growth potential. It emphasizes creating a radically mutual and balanced therapeutic relationship.
Mutual. What does that mean in practice?
It means the therapist's core role is to offer unconditional positive regard, basically. Deep acceptance congruence, which means being genuine and authentic and empathy. Crucially, the humanistic therapist deliberately refuses to position themselves as the expert on the client's life.
That's a really interesting distinction. Because CBT, for instance, sometimes gets criticized because the therapist is kind of the expert, right? They're identifying the distortions, teaching the correct way to think.
That's exactly the point humanistic approaches often make. The counter-argument is that relying too heavily on the therapist as the expert, the one with all the answers, might inadvertently stunt the client's own self-direction and capacity for growth.
Potentially creating a sort of dependency.
Potentially, yes, or at least not fostering the client's innate ability to find their own solutions. The humanistic approach is really designed to foster authentic, lasting personality growth by empowering the client, trusting their inner wisdom, and drive towards self-actualization. It's about unleashing potential rather than just fixing problems.
It's a really compelling philosophical difference. But, okay, let's talk effectiveness. When we look purely at the data symptom reduction for things like depression or anxiety, how do these different styles actually stack up? I seem to recall the research suggests the results are surprisingly close.
They often are, yes. Research, including numerous studies and meta-analyses, consistently shows that psychodynamic therapy particularly the shorter-term versions, often called short-term psychodynamic psychotherapy or STPP, can be just as effective as CBT in reducing depressive symptoms.
Just as effective.
In many cases, yes. And furthermore, some research suggests psychodynamic work might lead to improvements in broader life outcomes beyond just the main symptom score. Things like anxiety levels, chronic pain perception, overall quality of life.
What about for anxiety specifically?
For generalized anxiety disorder, or GAD, studies comparing STPP and CBT have found that both approaches yield large and, importantly, stable positive effects when measured even 12 months after treatment ends.
Okay, that really raises an important question then. If the efficacy data often shows equivalence, especially for common issues like depression and anxiety, why does CBT still seem to hold this reputation as the universally promoted gold standard for structured therapy?
That's a really critical question, and the answer is probably multifaceted. Part of it is likely CBT's structure. It's highly manualized, meaning there are clear protocols and steps. This makes it easier to research in randomized controlled trials, easier to teach, and easier to replicate consistently.
So it fits the research model well.
It does, but the equivalence data strongly suggests that the active ingredient in therapy isn't always just the specific technique being used. Those common factors across different therapies, the quality of the therapeutic relationship, the trust built, the collaborative focus on the client's goals, these are incredibly powerful drivers of change.
The relationship itself heals.
To a large extent, yes. A caring, supportive, trusting relationship is absolutely essential, regardless of the modality.
Now, speaking of the relationship, we have to touch on dependency. It sounds a bit counterintuitive, but I remember reading that some level of dependence on the therapist, especially early on, can actually be beneficial.
That's right, but it's a delicate balance. It's like walking a tightrope. Early on, feeling some reliance on the therapist can provide a secure base. It might help a client feel safe enough to start exploring difficult feelings or to begin individuating from perhaps unhealthy relationships outside of therapy.
So it's like a temporary scaffolding.
Exactly. But, and this is crucial, that reliance must actively taper off as treatment progresses. The goal is ultimately self-reliance and empowerment. If the therapeutic relationship remains overly protective, or if the therapist subtly encourages excessive reliance, it actually undermines the client's agency.
That could be harmful.
It can be very harmful, yes. It risks reinforcing the client's feeling that they can't navigate life or trust their own judgment without constant external validation from the therapist.
Okay, so moving beyond the one-on-one relationship, let's explore therapy that happens within systems, specifically couples and families. This feels like a completely different way of thinking, shifting away from locating the problem solely within one individual.
It's a fundamental paradigm shift, absolutely. The systemic approach views psychological issues not in isolation, but as arising and being maintained within the context of family relationships and these complex interactions between individuals and their environment.
So the family itself is the client, in a way.
Often, yes, or at least the system of relationships is the focus. The underlying idea comes from general systems theory, which posits that a family isn't just a collection of individuals, it's an interconnected system, a dynamic whole. The system's behavior is more complex than just the sum of its parts.
And how does one person's issue affect the whole system?
Well, the theory suggests that one person's symptoms might actually be serving a function within the family system, perhaps maintaining a certain balance, however dysfunctional. Or the way the family functions profoundly influences how individual members develop and express problems.
Okay, one of the most successful and well-researched systemic methods, particularly for couples, is emotionally focused therapy, or EFT. What makes EFT so powerful?
EFT, developed primarily by Sue Johnson, is very strongly anchored in the science of adult attachment. It focuses on identifying and then modifying the negative interaction cycle, sometimes called the dance that couples get stuck in.
Yeah.
You know, the classic pursue-withdraw pattern or attack.
Right, those painful loops.
Exactly. EFT helps couples understand the raw, primary emotions, usually attachment fears, like fear of abandonment or feeling unworthy that are driving those cycles. By bringing those underlying emotions to the surface in a safe way, it helps partners reconnect and build a more secure emotional bond.
So it changes the emotional music of the relationship.
Beautifully put, yes. The process helps both partners develop a more secure sense of self within the relationship and dramatically increases trust, responsiveness, and emotional intimacy.
And the research into what makes relationships work or fail often points to seemingly small, everyday behaviors, doesn't it? Like the Gottman research.
It absolutely does. John Gottman's extensive research, observing thousands of couples, identified some really specific behaviors that are highly predictive of relationship longevity or dissolution. One key factor is how partners respond to each other's bids for connection.
Bids for connection. What's that?
It's any attempt to get your partner's attention, affection, or support. It could be big, like sharing bad news, or really small, like pointing out something interesting, sharing a bit of enthusiasm about your day, or even just making eye contact.
Okay.
Gottman found that how the partner responds to these bids is critical. If one partner consistently ignores, dismisses, or turns away from those bids, especially the positive ones, like sharing excitement, that pattern is a remarkably strong predictor of future relationship breakdown.
Wow. So just ignoring your partner when they say, look at that sunset, can actually be corrosive over time.
Over time, yes, it sends a message of, you're not important, or your feelings don't matter to me. It's the insistent habit of acknowledging, validating, and turning towards those bids that builds emotional capital and lasting stability.
Okay. Before we move on from relational help, we really need to draw a clear line between therapy and coaching. The boundaries can seem blurry sometimes, especially in the public eye.
This clarity is ethically vital. It's a really important distinction. Therapy is generally oriented towards the recovery of health, whether that's physical or emotional health. It often aims to address issues, pain, or psychological discomfort rooted in past events or ongoing clinical conditions.
Okay, recovery and addressing dysfunction. What about coaching?
Coaching, conversely, is typically oriented towards client growth and achieving future goals. It usually works with non-clinical populations, people who are generally functioning well but want to enhance their performance, achieve specific objectives, or maximize their potential.
But surely, coaches must encounter clients whose issues are more severe than just wanting to improve performance. Issues that might actually be clinical.
Absolutely, and that's where the boundary challenge becomes really critical. When does normal anxiety about public speaking cross the line into a debilitating social phobia? When does feeling blue become clinical depression? Coaches need to have very clear protocols and ethical guidelines for recognizing when a client's issues fall outside their scope of practice and require referral to a licensed mental health professional. They aren't trained or licensed to diagnose or treat mental health disorders. Making that distinction and referring appropriately is crucial.
Okay, this next section feels like a really significant paradigm shift in how we think about healing. We're moving from the top-down approaches, focusing mainly on thoughts and cognitions, to more bottom-up or somatic approaches. We need to talk about trauma, how it's stored in the body, and why traditional talk therapy sometimes just hits a wall.
This is such a critical area. It really highlights the limitations of relying only on cognitive engagement, especially for trauma survivors. Leading trauma research, folks like Bessel van der Kolk and Peter Levine, have demonstrated pretty convincingly that trauma isn't primarily stored as a neat narrative memory in the thinking part of the brain, the cerebral cortex.
Where is it stored then?
It seems to be stored more as raw sensation, unprocessed emotion, and physiological distress patterns lodged deep in the limbic system, the emotional brain, and even in the body tissues themselves via the autonomic nervous system.
Okay, so less like a story, more like a physical state.
Exactly. And this explains why, when survivors try to talk about their trauma in standard therapy, they often become physiologically overwhelmed. They might start hyperventilating, shaking uncontrollably, or conversely, completely shut down and freeze. That's the hypoaroused state.
And when the body's in that state.
When the body is in that state of intense fight, flight, or freeze activation, the thinking brain, the prefrontal cortex, literally goes offline. It gets inhibited. So the capacity for rational thought, reflection, narrative processing, it's just not available in that moment. Cognitive dialogue becomes pretty much useless, even potentially re-traumatizing.
So given that, how are we defining trauma in this more somatic context? Is it just about the bad event?
The definition shifts. It's defined less by the specifics of the external event itself and much more by its effect on the person's nervous system. Trauma, in this view, is an experience that causes long-term dysregulation and activation in the autonomic nervous system, ANS. The problem resides fundamentally in that dysregulated nervous system and the resulting emotional and somatic chaos.
Not solely in the memory of the event.
Not solely, no. If a person doesn't feel safe or comfortable in their own body, if their physiology is constantly signaling danger, purely talking about their history might not get to the root of it. The body is really the engine of feeling alive and safe.
This need for body-based intervention leads us directly to approaches like somatic experiencing, or SE.
Yes, SE, pioneered by Dr. Peter Levine, focuses intensely on tracking and working with perceived body sensations, the felt sense, as the primary pathway to healing trauma.
How does that work? What's the core principle?
The core principle is facilitating the biological completion of thwarted threat responses. When an overwhelming event happens, the body naturally mobilizes huge amounts of energy to fight or flee. But if fighting or fleeing isn't possible, maybe you're trapped or too small, that massive survival energy gets frozen or trapped in the nervous system.
Stuck energy.
Essentially, yes. SE uses gentle, guided attention to internal sensations to help the body safely discharge that trapped traumatic energy. This discharge often happens through natural, involuntary physiological processes like shaking, trembling, heat, or tears. It's the body finally completing the self-protective action it couldn't complete at the time of the trauma.
That sounds incredibly delicate.
Right.
How does an SE therapist guide someone through that without just re-triggering them and pushing them into overwhelm?
That's the art of it. They use a key technique called titration. It means approaching the traumatic material in extremely small, manageable doses, like adding 1 drop of a potent substance at a time. So the client might be guided to briefly touch into an intense sensation related to the trauma, say, tightness in the chest, but only for a few seconds. Then immediately shift their attention to a part of the body that feels neutral, grounded, or even pleasant.
Shifting between the charge and safety.
Precisely. This back and forth process is called pendulation. And alongside titration, there's a huge emphasis on resourcing. This means actively identifying and evoking positive internal experiences, feelings of calm, strength, stability, connection, even pleasure in the body. These resources build the client's capacity, their internal container, to tolerate the difficult sensations without getting flooded.
Building internal grounding first.
Yes, increasing the felt sense of safety and agency before approaching the really difficult material. It's all about expanding the nervous system's window of tolerance.
You mentioned the risk of overwhelm. I think the term used was the trauma vortex. That sounds pretty scary.
It is a critical concept in SE. The trauma vortex describes the self-reinforcing runaway feedback loop. The traumatic memory gets triggered, which activates intense nervous system arousal, anxiety, panic, rage, which leads to feeling like you're reliving the traumatic experience, which further reinforces the body's defensive posture and confirms the sense of danger. And round it goes.
Downward spiral.
Exactly. The SE therapist's primary job is to gently interrupt that destructive loop. By using titration, tiny doses, and constantly resourcing, bringing in feelings of safety and calm, they guide the client to experience the discharge, the shaking, the heat, without getting sucked back into the vortex and re-traumatized.
Okay. Let's turn to another very well-known and effective method for trauma. Eye movement desensitization and reprocessing, or EMDR. This one is also empirically proven, especially for PTSD, but the mechanism seems, well, almost strange to outsiders. How does moving your eyes back and forth actually help resolve a deeply traumatic memory?
It does seem counterintuitive at first glance, doesn't it? But EMDR is widely supported by research, and systematic reviews show its efficacy is generally equivalent to other gold standard trauma-focused therapies, like specialized forms of CBT.
Okay. So what's the theory behind it?
The core theoretical framework for EMDR is the Adaptive Information Processing Model, or AIP. This model suggests that psychological problems, like PTSD, result when distressing life experiences are inadequately processed by the brain's information processing system.
Inadequately processed. Meaning what?
Meaning the memory network associated with the trauma, the images, sounds, emotions, physical sensations, negative beliefs, remains kind of stuck, isolated, and unprocessed in the brain. It hasn't been integrated into the person's broader network of memories and understanding. It stays highly reactive.
Like a raw file that keeps getting opened.
That's a good analogy.
Yeah.
And EMDR aims to accelerate the brain's natural tendency to link up and process that isolated information, integrating it into more adaptive memory networks.
Okay, so how does the bilateral stimulation, the eye movements, or sometimes alternating hand taps or sounds actually do that? What are the proposed mechanisms?
There have been several theories proposed over the years. One early idea involved activating an orienting response along with a relaxation response. The repetitive movements capture attention while perhaps simultaneously inducing some relaxation, allowing the person to engage with the distressing memory without becoming completely overwhelmed or avoidant.
Okay. Is that the main theory now?
Probably the most robust and currently favored theory is the working memory account.
Working memory. Tell us more about that.
Okay, so working memory is your brain's mental workspace, the limited capacity system that holds and manipulates information for immediate use. Think of it like your computer's RAM. It's finite.
Right, you can only juggle so much at once.
Exactly. The working memory account proposes that the bilateral stimulation, making your eyes track the therapist's fingers back and forth, or focusing on alternating hand buzzers, actively taxes this limited working memory capacity.
And uses up processing power.
And precisely. So when you try to hold the traumatic image or memory in mind while also engaging in the demanding bilateral stimulation task, it creates cognitive load. There isn't enough working memory capacity to do both fully.
And the effect of that is.
The effect seems to be that the vividness and the emotional intensity of the traumatic memory are reduced each time it's recalled during the bilateral stimulation. It becomes less hot, less emotionally charged, feels more distant, more like a regular memory from the past rather than something happening right now.
That's fascinating. And there's actual physical evidence that EMDR changes brain function related to trauma.
There is, yes. Neuroimaging studies have shown that successful EMDR treatment is associated with changes in brain activity. Specifically, metabolic normalization in deep brain structures often implicated in trauma, like the hippocampus and posterior cortical regions involved in memory and sensory processing.
So the brain regions calm down.
Some regions seem to, yes. And crucially, studies also often show increased blood flow or activity in the lateral prefrontal cortex.
The thinking part of the brain.
Exactly. This supports the idea that EMDR helps strengthen the prefrontal cortex's ability to regulate or inhibit the hyperactive limbic subsystems, the amygdala, for example, which are responsible for those raw emotional reactions and fear responses. Essentially, the thinking brain seems to successfully regain top-down control over the emotional brain's reactivity to the trauma memory.
Wow. Okay, so beyond these very specific, well-known modalities like SE and EMDR, we're also seeing other somatic and brain-based interventions proving valuable for healing trauma.
Absolutely. We really should mention the growing body of evidence supporting the use of specialized trauma-informed yoga practices. Studies have found it can significantly reduce PTSD symptoms, with effect sizes sometimes comparable to established psychological treatments.
How does yoga help with trauma specifically?
Yoga, particularly styles that emphasize mindfulness and interoception, awareness of inner body sensations, helps traumatized individuals gently re-inhabit their bodies. It helps them learn to tolerate the physical and sensory experiences associated with fear, anxiety, and helplessness in a safe, controlled way. It increases bodily awareness and potentially improves emotional regulation skills through breathwork and mindful movement.
And for really chronic, persistent PTSD, or maybe cases resistant to other therapies, are there more direct brain interventions?
Yes, that's where techniques like neurofeedback come in. Neurofeedback works by monitoring a person's brainwave activity in real time, usually via sensors on the scalp, and providing immediate feedback, often visual or auditory.
So you can see your own brainwaves.
In a simplified form, yes. The feedback allows the person to learn, often unconsciously at first, how to actively alter their own neural circuits to shift their brainwave patterns towards states associated with calm, focus, and regulation. It has shown positive results in reducing PTSD severity scores and problems with emotional dysregulation. It's like physical therapy for the brain's electrical patterns.
Finally, just briefly, we should touch on the importance of context, or set and setting.
Yeah.
If this seems particularly relevant in some of the emerging, more intensive therapeutic contexts, like maybe MDMA-assisted therapy for PTSD.
Absolutely crucial. The mindset, expectations, intentions, and psychological state an individual brings to any intensive therapeutic experience, and the setting, the physical environment, the therapist's presence, the overall sense of safety and trust profoundly shape the therapeutic response.
So the context has to be carefully managed.
Immensely so. For clinicians working in these contexts, optimizing the set and setting is paramount. This includes practices like building strong rapport, ensuring physical and emotional safety, and employing cultural humility, being deeply aware of how a client's cultural background might impact their experience, their vulnerability, transference dynamics, especially when non-ordinary states of consciousness are involved. These factors can get significantly amplified.
Okay, let's shift gears now into a domain that causes enormous psychological stress for so many people, but often isn't directly addressed in traditional therapy: our relationship with money. You're talking about financial therapy here, this really interesting intersection where deep psychology meets financial planning and behavior.
Yeah, it's a fascinating and rapidly growing field. It really operates on this core idea that for many people, arithmetic becomes autobiography. Our financial lives tell a story about our deeper beliefs and emotions.
Arithmetic becomes autobiography. I like that.
Financial therapy specifically looks at how our emotions, our memories, particularly from childhood, and our relationship patterns shape our present day financial behavior, how we earn, spend, save, invest, or avoid money.
So it requires expertise in both areas, therapy and finance.
Ideally, yes. True financial therapists need competency in both therapeutic principles and financial concepts to genuinely help people change not just their budgets, but how they think, feel, communicate, and behave around money. We're moving way beyond just spreadsheets and into core beliefs.
And these core beliefs about money, often unconscious, formed way back, are sometimes called money scripts, right? Our sources identified three, maybe four major types. Let's start with the one often linked to self-sabotage, money avoidance.
Right. Money avoidance scripts involve this unconscious, often deeply held belief that money is fundamentally bad, dirty, corrupting, or maybe that oneself is inherently undeserving of wealth or abundance.
And how does that belief actually play out in someone's life?
Well, it can manifest in ways that seem totally illogical from a purely financial perspective. People with this script might unconsciously sabotage their earning potential. Maybe they avoid promotions or starting a business. They might chronically undercharge for their services. They often avoid looking at bank statements or bills because it causes too much anxiety.
Actively avoiding engagement with money.
Yes. Or they might engage in behaviors like excessive spending, compulsive buying, or giving money away impulsively almost in an effort to have as little of this bad thing as possible. Unsurprisingly, this script is strongly associated with poorer financial health outcomes, like lower income, lower net worth, and higher risk of debt problems.
Okay, then you have almost the mirror image, right? The intense pursuit of money as the ultimate solution. Money worship.
Exactly. Money worship scripts are characterized by the deeply ingrained belief that money solves all problems, that more money will bring absolute power, total security, and crucially, increased happiness.
The if only I had more money, everything would be perfect idea.
That's the core of it. These individuals might feel driven by a constant sense of lack, like, I'll never be able to afford the things I really want unless they relentlessly accumulate more. This often includes what are called money status scripts, where self-worth becomes directly equated with net worth.
How does this show up behaviorally?
They might be prone to taking excessive financial risks, maybe getting caught up in get-rich-quick schemes. They might be workaholics, sacrificing relationships and health for income. There can be a constant dissatisfaction, even with high earnings, and often a tendency to put a huge premium on buying status symbols, the newest car, the biggest house, to demonstrate their success and worth.
And despite seeming like opposites, both avoidance and worship are linked to poorer outcomes.
Yes, because both are fundamentally driven by unresolved emotional needs and maladaptive core beliefs rather than rational financial planning.
So what does the research suggest is the healthier, more adaptive script around money?
The pattern generally associated with better financial health and well-being is called money vigilance.
Vigilance, okay.
This script focuses more on themes of frugality, saving, prudence, and discretion. People with strong money vigilance scripts tend to be careful with money. They prioritize saving for the future or for emergencies. They're often quite secretive about their finances and generally cautious about spending.
So, careful and planful.
Exactly. They tend to be highly disciplined savers and budgeters. Now, extreme vigilance can sometimes tip over into hoarding or excessive anxiety about spending any money, which isn't healthy either. But in its balanced form, this script is strongly associated with healthier financial behaviors, like having an emergency fund, paying off credit cards, and having a higher net worth.
It's really fascinating how these early, almost mythological beliefs about money can dictate behavior, even for people who achieve massive financial success later in life. Which brings us to this really interesting paradox, sudden wealth syndrome. An experience that seems totally contrary to the societal narrative that getting rich is universally positive.
This is one of the most powerful and counterintuitive insights from the research in this area. Achieving great wealth relatively suddenly, whether through inheritance, selling a business, winning the lottery, a huge settlement can actually be a deeply disorienting, stressful, and sometimes even traumatic experience, which is why it's sometimes described using that term sudden wealth syndrome, although it's not a formal clinical diagnosis.
Why is it so disorienting? I mean, isn't acquiring wealth supposed to be the dream? solve all your problems?
That's the cultural myth, but the reality can be very different. It's often profoundly disruptive because it shatters a person's existing identity and sense of self. The adjustment process often involves intense psychological symptoms that actually mirror classic grief responses.
Grief. Grief over getting rich.
Grief over the loss of their old life, yes. People experience profound identity confusion. They literally might not know who they are anymore, outside of the context of their previous financial reality or struggle. They often report feeling isolated from former friends and family.
What other symptoms show up?
You often see impulsivity, especially in spending, as they try to figure out what this wealth means, or paradoxically, the complete opposite. Intense paralysis over making any financial decisions, leading to uncharacteristic passivity and avoidance. There's often guilt, anxiety, suspicion of others' motives. It's a deep sense of loss of their old self, their old relationships, maybe their previous sense of purpose, the structure that financial constraints provided.
And the research suggests there's a predictable transition process people go through when navigating this kind of massive life change.
Yes, financial transitions, like any major life transition, are rarely instant. They unfold in stages. The research often outlines 4 key stages. First is anticipation, the period leading up to the event, if it's expected. Second is the ending. This is the stage of recognizing that some fundamental aspect of the previous life or identity is definitively over, triggering that grief response. Third is the passage. This is often the most difficult, confusing, in-between period where the individual struggles to adapt, make sense of the changes, and find equilibrium. It's a time of high stress and uncertainty. And finally, if the transition is successful, they reach the new normal, where the wealth and its implications are integrated into a revised life structure and identity. But this whole process can take years.
And here's where the societal narrative seems to make the problem so much worse. This idea of social incredulity, the fact that friends, family, the public often just can't or won't recognize this distress as genuine.
This is a huge compounding factor. It's the lack of empathy. Because achieving great wealth is so universally glorified in Western culture, individuals who express genuine emotional pain, confusion, or distress about it are often met with disbelief, ridicule, envy, or dismissed as being ungrateful, spoiled, or somehow fundamentally flawed. What have you got to complain about?
Right. Poor little rich person.
Exactly. And that societal dismissal forces the individual to hide their true feelings and symptoms. It shuts down the possibility of getting understanding or empathetic support from their social network precisely when they need it most. It ensures they feel even more isolated and alone during what is already a really critical and vulnerable period of psychological adjustment.
Okay, we have covered a lot of ground here. 5 really distinct dimensions of mental health approaches. But maybe the single most critical factor in whether any of this works, regardless of the specific modality, comes down to finding the right fit with the therapist and the approach. Let's talk about how you actually select a therapist and what red flags should immediately raise concerns.
The fit. Yes, it really is everything. Research consistently shows the quality of the therapeutic alliance. That relationship between client and therapist is one of the strongest predictors of positive outcomes, sometimes even more so than the specific type of therapy used.
So what should people look out for? What's a major red flag right off the bat?
Well, one thing to be immediately cautious of is therapists who exhibit what you might call modality arrogance.
Modality arrogance.
Yeah, therapists who strongly claim that their specific approach, whether it's CBT, EMDR, psychodynamic, whatever, is universally superior, the only way, or that it works for absolutely everyone and every problem.
Why is that a red flag?
Because mental health is just too complex and individual for a one-size-fits-all approach. Good therapists understand this. They should demonstrate flexibility, openness to different perspectives, and a willingness to tailor their strategies to your specific needs, history, and goals. Rigidity is rarely helpful.
Okay, so beware the true believer who thinks their way is the only way. Beyond that kind of attitude, what are some other big warning signs that might signal a poor fit or maybe even incompetence?
Okay, first, a really practical one. Check their training. Do they have appropriate, specific, accredited training in the modality they claim to practice? Especially for specialized approaches like EMDR or SE for trauma, you want someone properly certified.
Makes sense.
Oh.
What else?
Second, a subjective but important red flag is if you consistently feel exhausted or drained after sessions, not in a good, worked hard way, but because you feel like you're repetitively going down the exact same conversational paths week after week without any new insights, progress, or sense of movement. Therapy should feel productive, even if it's challenging.
Stuck in a loop.
Exactly. Third, And this is a subtle but crucial one. If your close friends or family members seem to easily grasp the core of your problem or what you're struggling with, but your therapist consistently seems to miss the point, misunderstand your goals, or fail to grasp the underlying situation, that's a serious sign that something is off in the communication or their understanding. There might be a cognitive dissonance there.
But let's be clear here. A good therapist isn't supposed to just be a passive listener or a cheerleader, right? Growth often requires being challenged a bit.
Oh, absolutely. A good therapist should challenge you gently and respectfully. They should challenge self-limiting assumptions, help you see blind spots, introduce new perspectives that might be uncomfortable at first. They are definitely not there just to agree with everything you say or be a yes person.
So challenge is good, but how should it feel?
It should feel constructive, aimed at helping you grow, not like shaming or intentional criticism. They should help you see where your self-narratives might be flawed or where your behaviors might be counterproductive, but always from a place of care and aiming for your benefit.
And what if there is conflict? What if the therapist says something that hurts or feels off?
That's actually a really important point. Conflict, or what therapists call ruptures in the relationship, are normal and can even be therapeutic if handled well. The ideal response from you is to actually bring it up directly with the therapist. When you said X, I felt Y.
That takes courage.
It does. But a good, self-aware therapist will be open to hearing that feedback. They won't get defensive. They'll explore it with you and ideally engage in what's called repair, acknowledging the impact, maybe apologizing if appropriate, and working to understand and mend the rupture. Their ability to handle these moments actually demonstrates their relational competence.
Okay, let's shift to the practical side. For someone listening who has never been to therapy before, what should they generally expect in that very first session? What happens?
The initial session, often called an intake session, is primarily about gathering information and, crucially, establishing a sense of comfort and connection. The therapist will want to understand why you're seeking help now, what specific issues or goals brought you through the door.
So the presenting problem.
Yes. They'll also meticulously go over your history, your psychological history, any past therapy, diagnoses, your medical history, and definitely your family's mental health history, as genetic predispositions and family dynamics are often very relevant.
What else might they ask?
They might ask about your social support system, your coping mechanisms, both healthy and unhealthy. They might even ask about non-traditional methods you've tried, like talking to friends, self-help books, meditation apps, things like that. It helps them gauge your existing resources and perhaps your level of motivation or previous attempts to change. The overriding goal for that first session is really for both of you to get a sense if it feels like a potentially good fit and for you to feel comfortable and confident enough to proceed.
Okay, now let's tackle the elephant in the room for many people.
Yeah.
Cost. Therapy can be really expensive and often inaccessible. What are some of the more affordable options people might explore?
Cost is undeniably a significant barrier for many, but there are options. First, really utilize online therapist directories. Many allow you to filter providers specifically by the insurance they accept, whether they offer sliding scale fees based on income or their standard session rate. That can narrow down the search considerably.
Okay, filtering by price and insurance. What else?
Second, a fantastic and often overlooked option, especially if you live near a university or an academic medical center, is seeking care from a supervised trainee.
A trainee, like a student.
Yes, psychology doctoral students, psychiatry residents, social work interns, they often provide therapy in training clinics or hospital settings at a significantly reduced cost. And crucially, they are under very close, often minute-by-minute supervision by highly licensed and experienced senior clinicians. So you're getting high-quality care, often informed by the latest research, but affordably.
That's a great tip. What about the rise of online therapy and digital services? Has that changed the cost landscape?
Dramatically in many cases. Online therapy platforms and subscription-based mental health services have exploded in recent years. While quality varies, many offer therapy sessions via video chat, phone, or even text messaging at prices significantly lower than traditional in-person therapy.
How much lower?
It varies widely by platform and location, but in some major urban areas, these online services can sometimes start at a cost equivalent to maybe a quarter of a single typical in-person session fee, sometimes even less for basic plans. This expansion of teletherapy is definitely making care more accessible and affordable for many.
Okay, finally, let's cover the ethics around ending therapy. Termination is a really critical stage. How should that process work ideally?
Ideally, termination, the ending of the therapeutic relationship, should always be a collaborative process. It should be discussed well in advance, planned for, and reflect that the therapeutic goals have been met or that the client feels ready to move on. It should feel like a successful completion of the work.
What if the client needs to stop for external reasons, like moving or financial issues?
If a client needs to stop therapy for reasons unrelated to goal completion, the therapist still has an ethical duty to manage that process properly. This includes discussing the reasons, processing feelings about ending, and crucially, providing appropriate referrals for continued care if needed.
Which shouldn't happen.
What is considered very poor conduct, ethically, is abrupt termination by the therapist without sufficient notice, without a clear rationale, and especially without providing adequate referrals. This is often referred to as client abandonment, and it's a serious violation that can result in disciplinary action from licensing boards.
Okay, and what if a client encounters genuinely unethical behavior from a therapist, something beyond just a poor fit? What's the recourse?
If you believe you've experienced unethical behavior, things like boundary violations, confidentiality breaches, discrimination, incompetence leading to harm, or abandonment, you absolutely have recourse. You need to contact the specific licensing board that governs that therapist's profession, psychology, social work, counseling, etc., in your state or region.
And how does that process work?
Generally, official complaints must be submitted in writing, often through an online portal or by mail, detailing the specific allegations. The board will then investigate. For relatively minor violations, the board might handle it through mediation between the client and therapist, or perhaps issue a confidential letter of warning to the licensee.
And for more serious cases?
For more serious ethical breaches or patterns of misconduct, the consequences can be much more severe, potentially leading to the suspension of their license, mandatory supervision or retraining, or even permanent revocation of their license to practice. It's a crucial mechanism for protecting the public. Hashtag outro.
Wow. This has been a really necessary, I think, and definitely expansive deep dive, trying to bring some clarity to what is just a vast, sophisticated ecosystem of mental health care.
It really is an ecosystem.
Yeah. We've journeyed all the way from the logical cognitive restructuring of those automatic negative thoughts in CBT, through the crucial balance of acceptance and change in DBT, into the intricate dynamics of relational systems, and then right down into the profound neurobiological healing that seems possible with body-based methods like somatic experiencing and EMDR.
And I think if there's one overriding takeaway from exploring all these different approaches, it's that your well-being really hinges on finding the right mechanism for the specific problem you're facing.
Right. Is the root of the pain primarily cognitive? Is it tangled up in relationship patterns? Is it stored somatically in the nervous system from past trauma?
Exactly. And if we circle back to the very foundation of the mind, those negative thoughts, those core beliefs we talked about, even those money scripts, we realize just how much of our suffering often comes from the flawed, incomplete, or unexamined stories we unconsciously tell ourselves about who we are, what we're capable of, and what our past experiences mean.
And that, I think, is where the immense power of gaining this kind of knowledge really lies. It highlights that our objective circumstances, the things that happen to us, don't necessarily have to determine our life stories.
That's such a crucial point. What the research across many of these fields consistently shows is almost the opposite. The way we narrate our lives, how we make sense of, edit, and internalize our experiences, that profoundly determines what those lives ultimately feel like and become.
That's the danger, isn't it, of getting stuck in flawed, painful narratives. But it's also their incredible potential power. If we can find ways to critically examine, understand, and maybe successfully rewrite those narratives.
We can fundamentally change the outcome. We can change our future.
Exactly.
So as you, the listener, integrate all this structured information and maybe consider the various pathways forward for yourself or someone you care about, here's maybe one final provocative thought to mull over.
Okay.
Despite the seeming complexity of all these different approaches, the cognitive, the emotional, the relational, the somatic, consider the simple underlying idea. Perhaps many of our persistent emotional conflicts are, at their core, just predictable, often protective, responses emerging from the present moment interacting with old, isolated, unprocessed memory networks, loops from the past playing out now.
Unprocessed memories driving present reactions.
Yeah. So the question to ponder is, what single small step could you maybe take today, safely, to gain just a slightly new, more integrated perspective on one of your own most deeply held, perhaps painful emotional narratives?